Все работает.
Все, спасибо. Good afternoon. I'm sorry we are late in a few minutes because of the technical problems. And let's start our previous lecture. Injuries in maxillofacial area. Since time immemorial, soft tissue injuries to face have been documented in literature and even depicted in sculptures reflecting the image of society. In a polytrauma, the face may be involved or other may be isolated injury to the face. The face consists of several organs and aesthetic units. The final outcome depends on initial wound care and primary repair. Disfigurement following trauma becomes a social stigma and has gross detrimental effect on the personality and future of the victim. Injuries classified as maxillofacial include soft tissue injuries to face and intraoral structure, including lacerations, abrasion, and contusions, and a lot of other. Fractures to any of the facial bones, dental injuries, including impaction, subluxation, avulsion, and fractures of the teeth or alveolar bone, and temporomandibular joint dislocation. Soft tissue injuries may or may not have associated fractures. The aim of management is functional and aesthetic recovery in the shortest period. Various types of injuries occur depending on etiology and mechanism of injuries. Casual factors of these injuries include road traffic accidents, interpersonal violence or homicidal injuries, domestic accidents, false gunshots, industrial accidents, sport-related injuries, animal bites, and iatrogenic injuries. They can affect the skin, subcutaneous tissues, muscles, fat, nerves, blood vessels, salivary glands, and eyes. Quite oftentimes, depending on the force of impact, soft tissue injuries are associated with regional bone injuries, sinus injuries, and well as vary in levels of the brain injuries. In open wounds, the skin is cracked open, leaving the underlying tissue exposed to outside environment, which makes it more vulnerable to bleeding and infection. It's further classified as incised wounds, laceration or tear wounds, abrasions or superficial wounds, avulsion, puncture wounds, penetration wounds, and gunshot wounds. However, in closed wounds, the skin is intact and the underlying tissue is not directly exposed to the outside world. Acute wound is any surgical wound that heals by primary intention or any traumatic or surgical wound that heals by secondary intention. And later we'll talk about different types of intention and differences between it. An acute wound is expected to progress though the phase of normal healing, resulting in the closure of the wound. Chronic wound is the wound that fails to progress healing or respond to treatment over the normal expected healing time frame. Usually it's less than 4 weeks and becomes stuck in the inflammatory phase. This pathologic inflammation is due to a postponed, incomplete, or uncoordinated healing process. Wound healing is delayed by presence of intrinsic, for example, diabetic or some ulcers because of the ischemia of the various factors, and eccentric factors including medications, poor nutrition, comorbidities, or inappropriate dressing selection. Facial injuries themselves are rarely life-threatening but are indicators of the energy of injury. The types of soft tissue injuries which are classified depending on their course include abrasion, tattoos, simple or complex lacerations with loss of tissues, avulsions, bites, burns and contusions. And a few words about each of them. Abrasion. What is abrasion? Abrasions are superficial epithelial wounds caused by frictional scraping forces. When extensive, they may be associated with fluid loss. There's usually not a lot of bleeding, but the wound needs to be scrubbed and cleaned to avoid infection, and superficial foreign bodies should be removed. Laceration. Laceration is the deep cut of tearing of the skin. Accidents with knife, tools, and machinery are frequent causes of laceration. In the case of deep lacerations, bleeding can be rapid and extensive. And as you see on this slide, photos with patient with abrasion of the face. And here, surgical incision or lacerated wound. Of course, it's a clean wounds. Surgical incision is the type of the laceration when cause minimal tissue damage. They are made with precision in an environment where aseptic and antiseptic technique reduce the risk of infection, with the best of instruments and the facility to control hemostasis. Penetrated trauma may involve minimal damage to skin and connective tissue, though deeper damage to vessels, nerves, and internal organs may occur. And bite wounds. I hope you understand what are the differences between bite wounds and other types. First of all, it's different bacteria or toxins may be present and depending on the source, animal bites or even human bites. Puncture and avulsion. A puncture is a small hole caused by a long, pointy object such as a nail or needle. Sometimes a bullet can cause a punctured wounds. Punctures may not bleed in much, but these wounds can be deep enough to damage internal organs. And avulsion. Avulsion is a partial or complete tearing away of the skin and the tissue beneath. Avulsion usually occurs during violent accidents such as body crushing accidents, explosions, and gunshots. They bleed heavily and rapidly. And here we have photos with punctured wounds. Punctured and avulsion years. There may be ecchymosis, edema, subconjunctival hemorrhage, crepitus, hyperesterasia, evidence of facial nerve palsy, inadequate excursion of the muscles of expression and mastication, wound with or without exposed vital structures and fractures. Usually horizontal injury across the face is likely to damage more vital structure than a vertical injury, as it passes through more numbers of zones. In deep injury, it's necessary to evaluate communication with oral cavity, nasal cavity, and maxillary or frontoethmoid sinuses. And the last type of soft tissue injuries is contusions. Contusions are caused by more extensive tissue trauma after severe blunt or blast trauma. The overlying skin may seem to be intact but later become non-viable. Large hematomas under the skin or in the muscles may coexist. If they are superficial and fluctuant, they can be evacuated with the overlying necrosed skin. Ultrasound scanning or MRI may help to define a hematoma unamenable to evacuation. Extensive contusion may lead to infection. The risk of infection in traumatic wounds is reduced by adequate wound cleansing and debridement with the removal of any non-viable tissues and foreign material. If severe contamination is present, broad-spectrum antibiotic prophylaxis is indicated and should be extended as specific therapy as recommended for surgical wounds that are classed as dirty or when there are early signs of infection. Traumatic wounds need tetanus prophylaxis. These wounds need extensive debridement down to available tissues and should be left open until healthy granulation tissue has formed. Repeated debridement may be necessary. Alternatively, if the combination of wound contraction and epithelialization will leave an accessible cosmetic appearance, a wound may be left to heal by secondary intention. Human and animal bites are traditionally managed in this way, but primary closure can be done after wound debridement and excision of non-viable tissues. Different types of wounds you can see on this slide: clean wound, clean or contaminated wound, particularly contaminated wound, and infected wound. And here you can see different wound healing processes. We can divide into three phases or types: inflammatory phase, proliferative, and remodeling phase. Inflammatory phase occurs immediately after injury. Tissue damage initially causes the disruption of vascular vessels and extravasation, followed by the production of temporary platelet, plaque, and fibrin clot, which stop bleedings and adequate subsequent infiltration of inflammatory cells, causing heat, redness, pain, swelling, and loss of function. It's all features of inflammation. Wound exudates may be present, and this is also a normal body response to an injury. Second phase or next, during the proliferative phase, which occurs several days after tissue damage, keratinocytes and endothelial cells proliferate and migrate to a wound, resulting in re-epithelialization and angiogenesis. The wound will become smaller as it heals. And maturation phase, it lasts from 24 till 1 year, 24 days till 1 year. Finally, in remodeling phase, some fibroblasts are stimulated by microfibers and to differentiate into microfibroblasts, causing wound contraction. During this phase, production of the extracellular matrix, including collagen, proteoglycan, and fibronectin, is increased, which results in formation of mature scar. All of these events require the orchestrated efforts of different types of cells. Failure in any of these phases of the wound healing process can lead to chronic wounds, hypertrophic scars, and/or wound-related tumor formations. And here on this slide you can see photos with different types of scars, and of course it's a process of unfortunate maturation phase. Types of healing. First of all, of course, it's a primary intention. The wound edges are held together by artificial means such as a suture, staples, tapes, or tissue glue. There is minimal tissue loss, and wound heals without minimal scarring. Most clean surgical wounds and recent traumatic injuries are managed by primary closure. And in sometimes we can talk about delayed primary intention when the wound is infected or requires more thorough intensive cleaning or debridement. Primary closure usually from 3 to 7 days in duration, may be used for traumatic wounds or contaminated surgical wounds. And secondary intention, it's a spontaneous wound healing, occurs through a process of granulation, contraction, and epithelialization. Results in the scar formation and used as a method of healing for pressure acute surgical or traumatic wounds, for example, sinus, drained abscess, skin tear, or superficial lacerations. Facial wounds without additional injuries are repaired as soon as possible. In major trauma, while instituting the resuscitative measures, the wound may be dealt after 4 to 6 hours. Lacerations with will require straightforward closure. In cases of loss of tissue, two-dimensional and three-dimensional measurement of the wound is taken to assess the size of the tissue required to cover. In acute wounds, all the devitalized tissues are debrided conservatively. And in some wounds, for helping of wounds healing, we need to do skin grafts. And on this slide you can see structures and photos of real patients with skin grafts. It's a removal of part of full thickness segment of epidermis and dermis from its bloody supply and transplanting it to another site to speed up healing and reduce the risk of infection. Or flaps. The surgical relocation of skin and underlying structures to repair a wound. Flaps are named according to their tissue components and may include an anastomosis of blood supply to vessels attached to or at the affected sites. And here you can see different types or different stages of flaps to reconstruct trauma of the nose. And you can guess that it was the cancer of the or basilioma of the end of the nose. Dental injuries. Injuries to maxillofacial area commonly associated with the dental alveolar injuries. Careful inspection of the dentition and gingival mucosa will identify most dental injuries. Account for all of patients' teeth. Avulsed teeth may be displaced into the adjacent soft tissues or become aspirated, swallowed, or simply lost at the scene. In some times, radiographs may be necessary to locate missing teeth. Examination of the oral cavity begins with inspection. Remove all blood and debris from the oral cavity for examination. Record the location of the size of soft tissues injuries. Then we need to know presence of any empty socket or alveolar, which may indicate complete avulsion of the tooth. Gingival bleeding may occur as a result of laceration from the underlying fractures. Each tooth is then palpated to evaluate for mobility. Abnormal mobility may indicate a subluxation or non-displaced injuries or luxation displaced injuries of the involved teeth. Perform percussion of each tooth. Sensitivity elicited by percussion suggests a concussion injury in which the tooth generally is not mobile and displaced but has sustained an injury. Fractures of the teeth can be classified as a crown. Fractures involved the portion of the tooth above the gingival surface, and I hope you understand the crown part of the tooth, and root fractures. The Ellis classification system commonly is used to describe crown fractures, and Ellis first fracture involved the enamel only. The tooth appears normal in color but has an obvious irregularity in enamel surface. Ellis 2 fracture involves enamel and dentin, and Ellis 3 fracture involves the enamel, dentin, and the pulp. If in first two classes we can save pulp and save tooth alive, but in the third type, when the pulp involved in the fracture, and on this slide you can see enamel, dentin, pulp fracture, and you can see pulp through the in the crown part. We can save it, and we have to extract the pulp and save the tooth. Root fractures represented up to the 7% of the dental alveolar trauma. in permanent teeth. Suspect injury to root when bleeding from the gingival sulcus is observed. However, these injuries are best detected with radiographs. And here you can see different types of the root fractures, and in most cases of the root fracture we have to extract the tooth because its underlying underlying section of the tooth. Temporomandibular joint dislocation, and to understand the different types of temporomandibular joint dislocation, let's talk a few words about anatomical structure of the lower jaw. Lower portion of the face is dominated by the largest and strongest facial bones, the mandible or lower jaw. The mandible is made up of the body and two rami. The junction between body and rami is referred to as angle. The most anterior portion of the body is symphysis. The body serves as attachment for all of the lower teeth. The mental foramen containing the mental nerve and artery is located in the anterior portion of the body. The superior portion of the ramus contains the condylar process and the coronoid process, which are separated by the mandibular notch. The condylar process articulates with the glenoid fossa of the temporal bone to form the temporomandibular joint. Dislocation of the temporomandibular joint may be caused by trauma, generally by a blow to a chin while the mouth is open. It also may occur from a non-traumatic mechanism such as yawing, laughing, laryngoscopy, or prolonged dental work. The temporomandibular joint is the hinge and sliding joint. During normal mouth opening, the condyle rotates and translates forward to the area of the temporal eminence. In dislocation, the condylar head slides further forward and becomes locked anteriorly to the temporal eminence. Trismus and spasm of masticatory muscles prevent the condyle from the sliding back. A temporomandibular joint dislocation may occur in the unilateral or bilateral pattern. And here you can see photos of the patient with unilateral temporomandibular dislocation. And usually, of course, it's easily to understand by visual examination. The patient will present with difficulty talking and inability to close the anterior teeth, or even movement of the jaw is impossible. The patient with bilateral temporomandibular joint dislocation will present with a symmetric open anterior bite. In unilateral dislocation, the jaw will be deviated in the unaffected side. Palpation of the temporomandibular joint area may reveal the condylar head in abnormal position below the zygomatic arch. If the dislocation results from trauma, the remnant of undermandible, intraoral and facial areas should be inspected carefully and palpated to assess for any accompanying fractures. Most commonly, a reduction of the temporomandibular joint dislocation is performed via the intraoral route. To prevent trauma of the doctor's trauma fingers should be gloved with a thick gauze tapped securely on the both thumbs. To ensure adequate leverage, the patient should be positioned so that the mandible is below the level of the practitioner's elbows. Doctor place them thumbs upon the lower molars or on the ridge of the mandible intraorally, posterior to the molars, with the fingers wrapped externally around the mandibles. Apply firm, slow and steady pressure in a downward and posterior direction. If bilateral reduction is not possible, reduction may be done one side at a time. Reduction attempts that require excessive force should be aborted because they may cause iatrogenic fracture in the mandible condyles. And Of course, after the reduction of the temporomandibular joint, the patient should be instructed to avoid extreme opening of the mouth, such as may occur during yawning, laughing, and dental procedures. Pain relief may be achieved with non-steroid anti-inflammatory drugs. And let's talk about fractures. The facial area and its bone have typically been divided into upper, middle, and lower thirds. The upper portion, as you understand, it's overlying the frontal bone. The middle part consists of the nasal bone, maxilla, zygomatic bone, and zygomatic arch. And we are interested in all of them. And the lower portion of the face, it's a mandible. Let's talk about mandible fractures. Mandible fracture can be classified under various aspects such as location, type, completeness, number, and course of the fracture lines. Characterization by the anatomic sites involved in commonly the initial stage of the classification process. As I said, the mandible is the largest and main bone of the lower part of the face. And here you can see the structure of the mandible. Let's repeat. It consists of the symphysis part or body part. In the anterior part of the mandible, angle, it's between the bone or body part and rami. Then ramus and process, condyla and coronoid. And the last process or third process, it's alveolar process. And here you can see different types of classifications, and first it's classification by Kabakov and Malyshev according to the character or according to the dislocation, with dislocation and without dislocation. And it's most useful classification for the practice. And here on X-ray you can see mandible fracture, two lines of mandible fracture without dislocation. And on the right side of the slide you can see the fracture with dislocation of the bone parts. According to the number of fractures, line fractures, you can see that it can be single, double, multiply, unilateral and bilateral. According to the number, different classification, double and unilateral. And on the previous slide you can see single and double and unilateral and bilateral. And on this slide you can see double unilateral slide. X-ray, it's panoramic X-ray. What does it mean, double unilateral? It means that on one side we can find two line fractures. And here single bilateral. What does it mean? We can find the lines of fracture on the both sides of the mandible, in the right side and the left side, and one line fracture on each side. And you can see it by arrows. Multiple fracture. You can see X-ray of the multiple fracture, and of course cause of this fracture is car crash. Clinical assessment. Complete history trauma should be obtained after cardiopulmonary and vital and neurological function of the patient are stabilized. The mandible should be carefully evaluated by extraoral palpation. Mandibular contours such as ramus, lateral and inferior borders, and symphysis and parasymphysis area should be checked, and the continuity of the mandibular bone should be noted. Movements of the fragments can be evaluated by beam manual palpation. Ecchymosis and crepitus should be assessed. Checked mandibular movements. Deviation and restriction of movements should be evaluated considering condylar trauma. Also, the condylar head should be evaluated by palpation to check if it's in the articular fossa or not. Mucosal laceration, oral bleeding, ecchymosis and sublingual hematomas should be checked by intraoral inspection. Rule out fresh oral bleeding in the sublingual space or bilateral symphysis fracture to secure airway, especially for anticoagulant drugs users. Examination of the occlusion, including loose, fractured or missing teeth, should be performed carefully. A screening for mandibular fractures is the tongue blade test. Most patients with mandibular fractures will not be able to exert much bite force because of pain. The masseters are considered the strongest muscles in the body, and normal adults can usually easily blend and break the tongue blade, which is clenched between their teeth. Patients with mandible fractures are unable to perform this task without extremely discomfort, and difficulties performing this task should be considered at high risk for a mandible fracture. What for do we need this tongue blade test? For example, you see a patient, or you see car crash or some incidents, and you don't know how to transport this patient to the hospital if there are any fractures of mandible or not, because pain, of course, will be present in all types of injuries. You can ask the patient to buy this tongue blade or some sticks, and even for minimal bites, the patient will feel in a area of the fracture extremely pain, and he will show you and say that in this area I can feel pain, and you can understand that fracture is present. Of course, in hospital we don't use such methods. We use CT or X-ray for diagnosing. In most cases, clinical examination can be sufficient to intensively evaluate the entire fractures line, displace small fragments, root fractures of the teeth, and neighboring anatomical structures. Plain films, OPTG, and computer tomography can provide additional data about the fracture for better evaluation of the patients. Aim of fracture treatment. The purpose of the fracture treatment is to return the mechanical strength of the fracture site to its healthy state and to achieve the improvement in masticatory muscles' normal function. Fractures that are non-displaced and exhibit no occlusional changes may be enabled to non-surgical management, but the majority of mandible fractures will require stabilization for satisfactory healing and to restore pre-traumatic maxillomandibular orientation. Various treatment strategies have been described, and they vary widely depending on the fracture location and surgeon's preference. The patient's demographics, comorbidities, dentitions, and fracture characterizations will all influence the choice of fixation by the treating surgeon. The first stage of treatment is to return the fracture parts to their normal anatomical position. It's a reduction stage. And the second stage is a fixation of the parts in their normal anatomical position. If the history of trauma doesn't exceed from 8 to 10 days, the fixation of the fracture can be done manually. In order to control the pain, local anesthesia can be applied. Fractures of the mandible can be treated either with open method or closed method. Closed reduction, what does it mean? And you can see X-rays, panoramic X-rays and photos with close reduction. Anatomically, restoration of the fragments without visualization of the fracture line is close reduction. In close reduction, both tooth bone and bone-bone stabilization can be used to immobilize fracture to obtain correct maxillomandibular relation, which is called intramaxillary fixation or maxillomandibular fixation. It's usually based on closed method, or in Russia we named it as conservative method. Intramaxillary fixation is fixing the mandible and maxilla together when the teeth are occluded, so the patient can open his mouth for a certain period to allow secondary healing of the bone. In the closed method, arch bars are often used with ligature wires. The wire is passed through the interdental grab. One end of the wire is passed under the arch of the bar, and the other end is passed over the arch bar. With the fine-tipped tooth, the wire is placed under the cingulum of the tooth, and the wire is bent to secure the arch bar to the tooth. And as you can see on this photo, it's painful procedure. Of course, we do any anesthesia, local anesthesia, but nevertheless, patient feels pain. And of course, as you can understand by these photos, it's hard to brush such a widened tooth and hard to eat. The most important disadvantage of closed therapy is the continuation of extramaxillary fixation from 4 to 6 weeks. This may lead to undernourishment of the patient and weight loss. Although the patient must be informed about oral hygiene due to the difficulty in cleaning the teeth under the intramaxillary fixation. Non-displaced favorable fractures and grossly comminuted fractures with soft tissue loss can be candidate of close reduction and fixation. Maxillomandibular fixation can be performed with the use of Eric arch bars or IV loops, hybrid arch bars, intramaxillary fixation screws, circummandibular and piriform wiring, and orthodontic brackets with hooks. And on these photos you can see individual types of the wiring or arches with intramaxillary fixation. Open reduction is preferred when close treatment is not possible or has failed. In open reduction, there is a surgical approach to the fracture, and the fracture segments are repositioned to their anatomical position. This is followed by fixation steps. Fixation can be either rigid or semi-rigid in open reduction. Compression plates or bicortical screws are used in rigid fixation. While this is a reliable method and allows the patient to quickly return to daily functions. Semi-rigid fixation is performed using mini plates. These small plates are placed on the stress areas of the fracture. It is though that micro movements caused by semi-rigid fixation have positive effects on the callus formation. Monocortical screws are used so that anatomical structures are preserved. It may be possible to perform even under local anesthesia and with the internal approach. Occasionally, occlusion can be obtained using intramaxillary fixation and elasticity. The patient is given a soft diet during semi-rigid fixation. It's not mandatory to remove plates after healing. And here you can see open reduction methods with plates and screws. And of course, it's the best methods of fixation and reduction. And here I show you external type of fixation, and of course usually we use it if it's impossible to use any other methods, for example, according to the comminuted fractures with the loss of fragments, and it's quite difficult to use plates. Okay, let's do a break for 10 minutes and then we'll talk about fractures of the nose, zygomatic bone and arch fractures, and maxillar fractures. Алло, доброе утро. Разбудила? Разбудила, говорю. Слушай, что за дебил так ночью вообще? Я не могу понять, что он от меня хочет. Так он мне говорит, я говорю, в каком вы номере? Он говорит, ну вот как идете по коридору прямо и направо. А я говорю, шестой, он говорит, у нас два номера. Ну, там циферки есть, он говорит, ну да, но я типа не видела. Он говорит, у нас два номера. Я говорю, так в какой номер занести? Он говорит, в одном номере мы, в другом ребенок. Я говорю, подождите, а ребенок что у вас в отдельном номере? Он такой говорит, ну да. Я говорю, а сколько ребенку лет? Он говорит, 2 года. Я говорю, что он один в отдельном номере? Я думала, может он, знаешь, какую-то белку поймал. Он не так понял. А я же тебе написала, что он нашел походу. Я не стала звонить, думаю, может, не спишь. Ой, ясно. Нашли же мой телефон где-то, не знаю, где они его выцепали. Они нашли его, скорее всего, в Инстаграме. Стали искать, видимо, я нашел в Инстаграме. Потому что тут больше не... нет, там же папка лежит, и в папке мой номер телефона. В папке на мой номер телефона. А? Ну, ясно. Ну ладно, я на лекции, сейчас перерыв. Алло. Да, здравствуйте, Юрий Петрович, да. У меня, смотрите, у меня есть у третьего курса НБ. Вот если вам не сложно, возьмите мой журнал, там третий курс, там одна девочка. Смотрите, там, где холодильник, вот эта полка, синенький, вот откройте его, там получается третьего курса, англоязычный нет, англоязычные они все нормально, как бы все ходят. Нет, а третий курс, там одна девочка, которая вообще не... Умида, не помню фамилия. Вот она не ходит, вот она никогда не появляется. У них онлайн занятия, там написано группа ХПР, третий курс. Ага. Да, да, да. Умида ее зовут, я не помню, там 3 НБ у нее стоит. Да, 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 да. И она ни разу не появлялась. Вот сегодня за... Так октябрь, сегодня только 2 число. Ну все, тогда нет. Все ясно, ладно. Let's continue our lecture. Injuries of the nose are relatively common. In cases of facial trauma, nasal fractures account for approximately 40% of bone injuries. Fights and sport injuries account for most nasal fractures in adults, followed by falls and vehicle crashes. Nasal fractures may occur in isolation or in association with other facial injuries. Anatomy of the nose, as you can see on this slide, nose is made up of the bony part and cartilaginous framework. The bony nasal pyramid consists of paired nasal bones and the frontal process of the maxilla bilaterally. Classification. A lot of different types of classification, and we can use classification 4 or 5 types. First types, it's injury restricted to soft tissues. 2A and 2B, it's unilateral non-displaced fractures and bilateral non-displaced fractures. Third type, it's a simple displaced fracture. Fourth type, it's a closed comminuted fracture, and type 5, open comminuted fracture or complicated fractures. Nasal fractures can be classified on the scale depicting the severity of the injury. Isolated nasal fractures is usually caused by low velocity trauma. If the nose is fractured by high velocity trauma, then facial fractures are often and accompanied. And here you can see classification according to the types. And once more, as you can see, non-displaced fractures, unilateral and bilateral displaced fracture, close and open. Clinical features or inspection of the nose and the face. Of course, first of all, we'll find deformity and swelling of the nose or of the face, ecchymosis, epistaxis. The shape of the nose will be loss of anterior projection of the nose with increased intercanthal distance, suggests nasal orbital ethmoid fractures, and different pathologies with eye movements. Uncommon findings such as cerebrospinal fluid leak, posing as a clear rhinorrhea, subcutaneous emphysema, mental status changes, new malocclusion or limited extraoral movement should be prompt, immediate, specialty referral. This may indicate associated basal skull fracture or mid-face fractures by Le4. And as you can see on these photos, we can find nasal bleeding, and we can understand if it's only nasal bleeding, or in this fluid we can find cerebral spinal fluid or CFC. Of course, by visual examination it's impossible because blood is red and CFC is yellowish. We have to do some laboratories, and later we'll talk about the tests, how can we understand if it's isolated only nasal fracture or complicated with more severe cranial or base of cranial fractures. Principles of nasal fracture treatment, and as you can see, they are the same as a mandible fracture treatment. First of all, it's a reduction and then fixation of bone parts. Reduction we can divide into 2 big groups. It's close reduction and open reduction, the same as mandible fracture treatment. What does it mean, close reduction? It's a reduction with spatial instrument which we put inside the nose and then push out to place displaced fragments of the bones in their anatomical right position. And open reduction, it's a surgical operation. Usually we can use intranasal approach to do and to save cosmetics. Complications of the nasal fractures, of course it can be septal hematoma, and in sometimes we have to do incisions and to remove this hematoma. Septal abscess, vascular necrosis of nasal septum, cartilage leading to the saddle deformity, nasal obstruction, blowout fractures, extra-oral muscles entrapment and diplopia, nasal lacrimal duct injury, fracture of cribriform plate, and cerebrospinal fluid rhinorrhea, and inability to reduce. And usually it's of sports trauma, repeated sport trauma. Following fractures of the nasal bone, it's zygomatic bone fractures, and they are the second most common fractures of the face and predominantly occur in males. The zygomatic bone, in particular the malar eminence, plays an important part of the appearance of the face. It's a component of the lateral wall and flow of the orbit, as well as zygomatic arch. Moreover, it contains tiny holes also known as foramina, which allow for the passageway of important neurovascular structures. Fractures of the zygomatic bone can extend through the suture lines, namely the zygomatica frontal, zygomatica temporal, and zygomatica maxillary sutures. Furthermore, the lines of the fracture can also extend through an articulation the zygomatic bones has with the sphenoid bones gather wiring. As a result, in comminuted fractures, of course. Classification of the zygoma fractures. And as you can see, we can say about zygomatic body or tripod fracture and zygomatic arch fractures. Blunt trauma is the most common cause, and Benson's classification of zygomatic fractures is low energy, middle energy, and high energy fractures. Low energy fractures are those that don't result in displacement of the bone without displacement. This means that there may be a crack in the bone, but its alignment is not disturbed. Middle energy fractures are those that can moderate displacement and in some cases comminution. High energy fractures, for example from the MIVA, are those with severe displacement and comminution. This is the splintering of the bone into the multiple fragments. Other classification systems are based on the site of the fracture as well as the degree of comminution and displacement, whether interior, middle, and posterior. A patient with zygomatic fracture can present with a wide range of signs and symptoms depending on the kinetic forces that cause the result of damage. There will be certainly pain and limitation of the regards to movement that are associated with the zygomatic bone. If there is associated injury to the orbit and ocular structures, then there might be localized hemorrhaging as well as double vision. Patients may develop trismus. I hope you understand that it's an inability to fully open of the mouth or spasm of the masticatory muscles, usual masseter. And they have difficulty with opening the mouth, movements with the jaw, and of course chewing. They may be also bleeding through the nose, which depends on the severity of the injury. The correct bone of these patients may be flattened due to the malar eminence being depressed. There is a palpable step defect along the infraorbital rim, lateral orbital region, or zygomatic maxillary buttress. Furthermore, there is what may be referred to as a flame sign that arises as a result of the tender of the lateral canal being depressed and disrupted. Patients may also report paresthesia in the areas that supplied by the nerves that are affected by the injury. Of course, it's infraorbital nerve. And here you can see CT scan, and by red arrows I show you the lines of the fracture of the zygoma and zygomatic arch. And on the right side of the slide you can see step, red step. It's a symptom of the step which we can find due to fractures with dislocation of bone parts. We can easily palpate it by infraorbital rim, and for example, we can find it by palpating mandible, if it's a mandible fracture with a dislocation in the lower part of the mandible. And if we palpate this symptom of the step, you can easily understand that it's a fracture with dislocation. And here CTs with fractures. And what is interesting on this CT, air fluid level, and you can see the line of air fluid level. Of course, it's blood sinus, blood inside the sinus, and in some cases it's needed for treatment, but in some cases it doesn't need for treatment. Surgical treatment of the zygomatic complex fracture, and as you can see and as you can guess, we can divide into close reduction techniques and open reduction techniques. And I show here you the pictures with close reduction techniques. It's very useful and easy to do for surgeons and for patients. If it's successful, it's a great for the patient, because such difficult traumas can be easily treated. And as you can see here, it's a bone hook or reduction of the zygomatic complex. We can use hook of Limburg. Of course, before this procedure we have to do local anesthesia, and after then palpate the lower border of the zygomatic bone and zygomatic arch. It depends on where we can find the fracture line, and then put this hook under the bone, through the skin, through the fat, and through the muscles under the bone, and then push it out to put the zygoma in the right anatomical position. And how can we understand if it's successful or not? Of course, by palpation of the infraorbital rim. It's the first, of course, doctor palpate this rim to understand if the symptom of the step eliminated. If everything is okay, we can ask the patient to open and close his mouth. And as you can understand, if it's a fracture with dislocation, patient couldn't move, couldn't do any movement of the mandible. And if it becomes possible and patient can close and open the mouth, and the patient will say you that yes, I can move with it, the doctor can understand that it's successful operation. If these signs are not successful, and after the operation, after this bone hook reduction, you can see you can palpate a symptom of the step, and patient can't open the mouth. Of course, we need open reduction techniques. And here you can see open reduction techniques. Of course, there are a lot of approaches for the surgical incisions, intracellular, intraoral, or transcutaneous, and it depends of severity of the trauma and kind of the trauma. And we can have approach through the maxillary sinus. And usually, of course, we use plates and screws to fix the bone parts together in an anatomical position, and then, of course, this wound is sutured. And as you can understand, it's a lacerated wound, surgical wound. And here, photos with open reduction. Photos and CTs of patients with zygomatic arch before treatment and after surgical treatment. And the last biggest bone of the face, it's a maxilla. Maxilla is most frequently maxilla fractures most frequently result from the high-speed deceleration crashes in which the midface of maxilla strike stationary objects. For example, it can be dashboard or pavement. These injuries may also be produced by striking the face with the rigid objects, tire iron, baseball bat, and others. The Lefort classification system attempts to distinguish according to the plane of the injury. And of course, it's most widespread classification, but you have to understand that a lot of different lines of fracture can be. Lefort 1 level fractures are essentially separation of the hard plate from the upper maxilla due to transverse fracture running through the maxilla and pterygoid plates at a level just above the floor of the nose. And as you can see, it's a separation of the alveolar process of the maxilla from the maxilla body. And here you can see CTs with such fractures of the maxilla. Lefort 2, it's a pterygoid, or it's a, pyramidal maxillary fracture. These fractures transect the nasal bones, medial anterior orbit walls, orbital floor, inferior orbital rims, and finally transversatively fracture the posterior maxilla and pterygoid plates. And here you can see the patient with Lefort 2 fractures. CTs with it. And Lefort 3 is also known as a craniofacial disjunction because the entire mass of facial bones is separated from the cranial base. This is the highest level of Lefort fractures and essentially separates the maxilla from the skull base. The fracture is a transverse separation of the nasofrontal suture, medial orbital wall, lateral orbital wall, or zygomatic frontal suture, zygomatic arch, and pterygoid plates. It's recognized that many fractures depart from the defined classic fractures descriptions. As with any initial evaluation, the greatest priority is a primary survey, which consists of the ABCs, airway, breathing, and circulation. Once this secured, the detailed history of the event should be ascertained from the patient, witness, or first responders. First, the surgeon should inspect the patient's face and assess symmetry. This may require different vantage points and, if open, hindered by the bleeding or significant ecchymosis. To obtain the best physical examination of the face, it's important that any caked on blood or debris be washed off to expose the full extent of the injury. Contusions and ecchymosis may suggest underlying bony involvement. On physical exam, Lefort fractures are often appreciated as a facial distortion and elongation, maxillary mobility, mid-face instability, and malocclusion. A bony examination should follow. When examining the maxilla, bilateral palpation is often helpful to help assess the for steps of both external and internal palpation of the maxilla is necessary. Assessing the stability of the upper jaw may be achieved by firmly pressing one hand against the patient's forehead and manipulating for the maxilla with the other. If only the maxilla moves, it's likely to be a Lefort 2 or a Lefort 1 fracture. If the nasal complex moves along with the maxilla, Lefort 2 fracture is likely. Ecchymosis, facial edema, subcutaneous hematomas, and epistaxis are often seen in maxillary fractures. The oral cavity should be assessed for mucosal laceration, ecchymosis, and the presence of the bone fragments. An injury to the mucosa may suggest either alveolar or palatal fractures. Examination of the patient's occlusion is vital and should be done in a neutral position. Ask the patient to open and close the mouth and then clench the jaw and see if there is any sensation of the bite being off. Even the smallest changes in occlusion can be immediately appreciated by the patient and is more sensitive than examination's assessment. If any abnormalities are encountered on the exam that may suggest underlying fracture, craniofacial computer tomography or CT scans should be ordered. And what else according to the maxillar fractures? Treatment, and as you can understand, it's more difficult to treat maxillary fractures because we can't use mandible as a bone fixation. We can use only unmovable bones to fix the maxilla to these unmovable bones. And of course, if zygomatic fractures are present, we can't use zygoma as this fixation bone. We can use only frontal bones. And the definitive Management of the Lefort fractures centers around the restoration of the functional occlusion and the reconstruction of stable bony functional contour. At the present time, the most common way of internal fixation fractures of the midface is with small plates and screws. It should be made clear that not all Lefort fractures require internal fixation, particularly minimally comminuted Lefort 1 fractures in patients with the full complement of dentation. If internal fixation alone is used to manage Lefort fractures, it's generally left in place for 6 weeks. Mandible and maxillary fixation is typically performed with arch bars and stainless steel wires. For endodontist patients, surgical splints and dentures secured to underlying bone with screws or with circummandibular and circumzygomatic wiring may serve as a basic of stabilization. Both mini plates and external fixation have been applied successfully to a treatment of midface fractures. And here you can see wirings to the zygomatic bone and to the frontal bone. On the right side, circumscribed wiring through the zygomatic arch. On the photo you can see screws and wirings to fix the mandible and maxilla together, and of course mini plates. Usually it's titanium mini plates with special screws. And external fixation, of course in nowadays we don't use it because it's too traumatic to the patient and too hard to use for the doctor, but in some cases we have not another types or another way to fix the maxilla and to heal it. That was all according to the fractures of the maxillofacial area. I hope it was interesting. If you have questions, you can ask them on our chat. If you don't have any questions and everything is understandable, thank you for your attention and goodbye.